We're starting the intermediate lower limb case here, guys. So welcome to each of you, Melissa and Anshal.
Anshal.
Anshal. Hi.
Yeah.
Who wants to go first?
Do you want me to go?
Come on,
Yeah,
we
you
need a
can.
volunteer.
Yeah.
Anshal, right. So I'll share the screen. Once you can see it, let me know so we can start your timer.
Yeah, timer on.
Okay, so we've got Miss PH, who is a 22 years old college student. She was going down the stairs a couple of days ago when her knee buckled underneath her. She didn't fall to the ground, but managed to hold on to the banister. And she's now coming to you complaining of pain and swelling. Tell me what you want to ask about in the history, and I'll tell you what the findings are.
Okay. So I want to know when it happened and whether
A couple of days ago.
Yeah, if she landed on. You said she didn't fall.
She didn't.
So I want to know how she's been walking since then. Has she been limping?
Yeah, it's painful, so she's been limping. Yeah.
And where exactly is her pain?
The pain is mainly on the inner side of the knee.
Okay. And has she experienced any clicking?
No, nothing so far.
Any locking or giving way of her knee?
What do you mean by locking?
So has she found that her knee is stuck in a position and she can't easily move it?
You mean bend it or straighten?
Either locked in extension or locked in flexion. Has she experienced any symptom of locking?
Right,
at
you're
all?
absolutely right. She's not been able to put it fully straight. It doesn't want to go fully straight.
Okay, fine. And has she had any prior injuries to her knees?
Yes, exactly. She did remember that she was playing basketball 2 months ago when her right knee was, the right foot was fixed on the ground. She twisted to the left to get the ball from somebody else, and she felt a pop and fell to the ground.
Okay, and since then, for the last 2 months, she's been able to mobilize on this knee?
It took a little bit of time, so she initially put some ice on it, and she was able to put weight, a little bit painful, but not that much.
Okay, and I'd also want to know, apart from basketball, does she have any other hobbies or any other sport that she plays?
Basketball is her main sport.
Okay, is she otherwise well? Any medical conditions?
No other medical conditions, thank you.
Any regular medication?
No, nothing. She's had a couple of painkillers for the first injury and for this last injury as well.
Okay. And the only other thing I'd want to exclude is there any history of amenorrhea or eating disorders, anything like that at all?
No.
Okay, fine. So in summary, this is a 22-year-old lady who has a history of a knee injury 2 days ago when running down a flight of stairs. It sounds like the primary injury was 2 months prior to that when she landed onto a fixed foot and twisted it whilst playing basketball. She has symptoms of pain and locking with a fixed flexion. She's unable to fully extend, and she plays basketball and is otherwise fit and well.
Yeah, exactly. So what would you want to do? Examine her?
Yes, so I'd like to proceed with examining her.
Can you comment on what you see on the pictures and then tell me what steps do you want to do further?
Okay, so on inspection, these are clinical photographs of a knee. I can see the right knee appears swollen in comparison to the left. I also note that on standing, she's holding it in slight flexion compared to the other side. I can't see any obvious patella deformity or patella baja, or the patella seem to be at the same level on these photos. As she's standing, I'd like to proceed by asking her to walk. I'd like to examine her gait to see if she's limping, if she's able to extend her foot.
She's limping a little bit. It looks like antalgic.
Okay, I'd also like to inspect from the back to see if there's any findings, any swelling or bruising to the back of her knee.
Nothing to mention. Same size of swelling, same size.
All right. I'd then ask her to sit on the examination couch, and I'd start by palpating to assess if there's an effusion. So I do this by milking down the thigh and then sweeping from medial to lateral and seeing if I can see a medial bulge, which would indicate an effusion.
Would you expect that to be positive here?
No, I wouldn't. If this is an intra-articular injury, it may not be.
Right. So
sorry, I wouldn't expect an effusion necessarily in this, no.
But what about this swelling?
So you can have a swelling because of injury around the knee. Sorry. So in this, I would expect her to have an effusion because she has had an injury in her knee. So I mean, I can see it visually anyway, but I'd also examine for it.
Right. Okay. Carry on.
Then I'd want to assess joint tenderness, so medial or lateral joint tenderness. I'd want to see if
She's
she can.
tender on the medial joint line.
Thank you. So I'd want to assess straight leg raise, and then while she does that, I'd also I'd assess at the same time if she's fully extending, as well as how far she can flex.
She's extending to the same extent that you can see on this picture on the X-ray, and she can flex up to 90, as you can see her on this picture as well.
Okay. I'd then move on to assess stability of the knee. So I'd want to assess valgus and varus stability by stressing the knee both varus and in a varus and valgus fashion. I'd also want to perform anterior draw. I do this by asking her to
Which
flex.
positions do you want to test the valgus and varus instability in?
So usually I would lift the leg and I'd have it as extended as she can. And in that position, I place valgus and varus stress and see if there's any opening of the joint or if there's any pain.
Right, nothing in for extension.
Okay, I'd also then assess it in flexion to see if there's any difference compared to extension.
What degree of flexion do you mean?
About 30 degrees, so you can do it at 0, 30, and 90 for completeness.
Right. No, there is no joint opening in either varus or valgus, but when you press the knee in varus, it's a bit painful.
In varus, it's a bit painful. Okay. I then go on to perform an anterior draw test. I do this by flexing the knee, usually sitting on the end of her foot after consenting her for that, and then placing an anterior force on the tibia to see if it subluxates against the femur. And also I can do Lachman's and pivot shift. All of these will assess for an ACL injury.
Right. The anterior drawer is not very conclusive. You cannot get many information from that. And this is her Lachman test. Can you describe what you want to do?
So with the Lachman test, I stabilize the thigh with one hand and grasp the tibia over the tibial tuberosity with the other hand and anteriorly translate the tibia against the femur. And there's various, you want to assess A for a firm endpoint and then also the degree of movement. So this is a positive Lachman's test, which is indicative of an ACL injury in her case. I'd also want to compare it to the other side just to make sure it's not normal for her. And then I'd complete my ACL examination with a pivot shift test.
How do you do that?
So with a pivot shift, I have the patient's leg extended. I internally rotate it. I place a valgus force on the knee, and then I flex the knee. And what I'm looking for is for the tibia to reduce as I flex the knee.
Right.
But for this to occur, you need an intact MCL and iliotibial band.
Can you always get the Lachman, pivot shift during the examination in the clinic?
No, it's best done in a relaxed patient in theatre.
Right. Okay. And that's what it looks like. So anything else that's important to you to assess? Now what's going on in your mind?
So I'm thinking this is an ACL injury. I'd also want to assess the menisci at this stage. I already know she has a fixed flexion injury, but I'd want to assess both the menisci, also the PCL for completeness.
Right. So differential diagnosis, ACL. Okay, I agree. Anything else?
ACL with a potential lateral meniscal injury. It could also be a multiligamentous injury involving other structures in the knee, such as the PCL.
No. How do you assess the PCL?
PCL, usually I'd look for a posterior sag from the side with both the knees flexed. You can also do a posterior draw, but yeah.
Right. There is no posterior sag. So what further investigations do you want to obtain?
Sorry, what?
Investigations do you want to get?
Okay, so I'd like to get an MRI scan. Assuming we've already had radiographs, then I'd want to get an MRI scan to further assess her injury. I'd then go on to counsel the patient. Okay, so these are sagittal MRI scans showing, I can see on here, I can't see an intact ACL. I can see the PCL is in continuity. I can see fluid both behind the patella, and I can also see what looks like a meniscal tear with extrusion potentially, but I'd want to see more slices and a coronal view to better delineate.
What do you mean
this.
by extrusion?
So you can. Sorry, so that might, in fact, if I can retract that, that might be a double PCL sign on the right, but I'm not very clear. I'd want to just look through a few more slices to be sure. And you can
Right.
sometimes see that in a bucket handle tear.
Right. Okay. And this is another slice.
Okay. So I can clearly see an ACL injury, complete rupture of the ACL. But again, I can see.
How can you say that?
Well, I
What
can't
makes-
see any fibers in continuity of the ACL at all. You'd normally see that going from anterior to posterior, almost in the other direction to the PCL, which you can't see.
Right. So what are you going to offer this patient?
So I'm going to discuss with her two possible courses of action. One is physiotherapy, which is a prerequisite anyway because she doesn't have full range of movement. So I would first start with preoperative physiotherapy and explain the importance of regaining a full range of movement. Thereafter, her option, there are a certain percentage of patients who do go on to have a reasonably functioning knee with that treatment, but the majority of young active patients will require operative intervention in the form of an ACL reconstruction. And so I will counsel her about this. I'll explain that there are risks associated with it, including infection, pain, stiffness, arthritis down the line, risk of re-rupture, risk of ongoing instability.
So
DVT.
you're not going to tackle that at all.
Sorry?
You're not going to tackle this pathology at all. What did you mention on the MRI she had?
Oh, the bucket handle tear as well, yes.
So just leave it.
Yes. No, I wouldn't leave that because that will also cause her ongoing symptoms. There's two options of managing this. Either, depending on the severity of her symptoms, you can either address it immediately with the ACL tear, or if, because she's got a flexion deformity, if we're not going to do an ACL immediately, we can address the bucket handle tear first.
Okay. Right. I think this is fair enough for now. Take a
2
deep
minutes.
breath, sit back and think, how do you think this station went?
So I think the initial bit was okay in terms of identifying the pathology, talking through the examination and the history. I think I was a little bit, I wasn't very fluent with the management in that I jumped back and forth a little bit, and I did initially forget the bucket handle tear part of it. So I could have been a bit more decisive about that.
Right, you've got a very good insight. You've identified, I would have given you 6 or 7 even for the history and the clinical examination. You've asked about the site of the pain, the site of tenderness. What you missed in the history was swelling. You never asked me about swelling.
I think it was on your slide.
No, yeah, okay, but then does it make any difference how soon did the swelling come up after the injury? Because
Yes.
I would have told you that it has happened in a couple of hours on the first case and on the second case. And if it's happened very soon, then the meniscal tear is a peripheral meniscal tear because these are the ones that bleed, and it's probably one that needs repairing. The other thing is you've quite rightly identified the flexion deformity and mentioned about the patella. With the patella in a patient who's given way, what you're interested on is whether it's Baha or Alta, it's whether it's lateralized as well, because it could have been a patellar subluxation or recurrent dislocation. When you were talking about the effusion, what I was aiming for is sweep test would give you the small or the minimal effusion, but with such a large effusion that you can see in her case, sweep test will be negative, but you will be able to detect either cross fluctuation or patellar tap. These are the signs for a bigger size of effusion. The killer is your treatment. I would have failed there because you completely forgot that a locked knee with a bucket-handed tear, 22 years old lady, plays basketball, and if you've asked about her sports level, she's playing for her university. So she's a very sporty lady, young, and she needs to go back to sport. So this bucket handle tear needs to go back in its place. You can't take it out altogether, especially if it's a large one with a peripheral tear, white, red on red. So it's a meniscal repair, and meniscal repair is an absolute indication for ACL reconstruction. Okay, thank you. Joe, sorry.
Yeah, thank you. That's right. If you can stop sharing. Thank you very much, Melissa. Hi. Your time starts now. You have been asked by the GP that this young lad, 6 years old, come from mid-Asia countries, and he is not happy with his appearance, and he came to you with mum. So tell me, what are the questions you want to ask to mum, please?
So I'd like to ask mum about a prenatal history, if anything was any problems in the pregnancy, any infections or premature birth. I'd like to know about the
No, there was no. Sorry. There was no any prenatal history issues.
Okay. Any problems in the birth or in the post-operative post?
She had a planned cesarean section, and the child was a healthy, boy, and he didn't need to stay in the hospital at all.
Okay. I'd like to know if the child has met their normal developmental milestones, so sitting, walking.
Yes, although she thinks that he was, slightly delayed compared to his cousins.
Okay, I'd like to know if there's any other children at home and if they have any similar problems at all.
Yes, there is his older sister had similar condition.
And anything that in the parents' side, any known problems with any diagnosis of height or structural deformity in the parents that they know of?
Yeah, the mother said that her family is brilliant as usual. Okay, it's the father's problem. Okay, his grandfather and himself was short. Okay.
I'd like to know if the child about a little bit about the child's schooling, if they go to a mainstream school or any different type of schooling.
No, he's good at schooling, although he's not playing as usual as the other children. He's not interacting in the PE and activity-wise, but his intellectual is good.
Okay, and I'd like to know a bit more about why he's not interacting. Is it pain or is it more of a fatigue? What's sort of stopping him playing so much with the other children?
Well, yeah, he's not that, as active as the other children, and he's not of the same physical, capabilities.
Okay, I'd like to know just a little bit more about the child as well, if they've ever had any problems with their neck or their spine diagnosed, or if they have any other past medical history.
She said that the medical care back home was really not good. And they said that these happens, he might have something from his father's side, and that's it.
Okay, and he's not known of any breathing problems when he was a baby that the mum tells me about? Nothing?
No, he didn't have any problems with his breathing, though.
Okay, I'd like to know, it doesn't seem like they've had any treatments so far, but I'd like to know if the child's on any medications. I assume probably not.
No, but he was... she was taking him to the optician to check his eyes.
Okay, and did that find anything at the optician?
No, but she thinks that he might be wearing need to wear eyeglasses like his father as well.
Okay, I would like to know, just to ensure if the dad or the child's known to be sort of quite stretchy or bendy at all.
No. She say that he's more stiffer than usual. Stiffer. People. Yeah.
And just like to get a feel from the mum if things have changed rapidly, or if this is sort of more of he's always been like this, and it's just that they're now seeking medical.
It's she's saying that it's slowly getting worse.
Slowly getting worse. Okay, and just to ensure there's not been any.
Okay, that's fine. Okay. That concludes your history time. we need to go to examination. Sorry to interrupt, but yeah, you have to go to examination. So tell me about how would you approach this child?
So I approached this child with a top to toe examination. So initially asking the child to walk around the clinic.
Before walking, would you like to comment on the pictures?
So looking at these pictures, I can see a picture of the front and the side of this child. It looks like he's got a sagittal plane deformity. He looks like he's short in height. It's difficult to tell if this is where the shortening is exactly coming from, because his shorts are covering quite a lot of his lower limb, but it looks like it's a symmetrical shortening with potential
symmetrical.
So in terms of, I think it's probably a level of rhizomelic shortening. It looks like his arm is shorter than his forearm, but I can't obviously see his thigh.
Rhizomelic. So rhizomelic defines the segment. What is symmetrical? Is there symmetrical shortening and non-symmetrical shortening?
No, sorry, I just meant that on both sides. I was just sort of.
Oh, okay.
Right,
okay.
sorry.
So no hypertrophy. Okay. All right. Okay.
So then I would like to fully examine the child, so expose them down to their underwear, looking at the spine, looking if there's any signs of any spinal.
Any problems with the spine you can see?
So it looks like he does have what is suspected as scoliosis. Looking at these clinical photographs, I'd like to explore that further. I would look for any signs of spinal dysgraphisms or any hairy patches or any
No hairy patches.
And I would like then to do a forward bend test to see if this further accentuates any deformity.
He can forward bend, and there is a slight rib hump or when he flexes forward. Yeah.
Okay, so I'd like to note down the side of that, and then I would like.
It's on the right side.
Okay, and now I'd like to examine his cervical spine movements. I would like to examine his hips if there's any signs of any scarring.
Why would you want to examine his cervical spine?
So in a child with a dysplasia, they can have problems with their cervical spine. So some atlantoaxial subluxation wouldn't really be picked up too much on an examination, but it would just be a part of my examination.
Okay, good.
And then I would like to go on to examine the abdomen, just make sure I can feel no abdominal masses.
No abdominal masses.
And then going down to the hips to see the range of movement here, and if this is painful.
It's limited.
And I want to know if it's limited in abduction or adduction or flexion.
Abduction, limited in abduction.
Abduction, okay. And then looking at
so there's no abduction.
No abduction, okay. So that might suggest a problem such as a DGH of the hip or a dislocation. And then I would like to go down to examine the knees, see if there's a flexion deformity and the range of movement and flexion extension and ligamentous laxity.
Okay, would you walk the child?
Yes, yes, I would.
Okay, so the child is swinging right and left.
Swinging right and left. Okay, so that's okay. So I'd like then to attempt this child to do a Trendelenburg's test. It can be difficult in this age group, but I would try and get them just to stand by me and live.
And then after examining him, what would you like to know when he lie flat on the bed?
I'd want to attempt to do a Thomas test to see if he's got any fixed flexion deformity. And I'd also like a Galeazzi test to see if where his leg length discrepancy. Or
it's femoral. It's above the knee.
Above the knee. Okay.
Would you do anything further?
I can draw with my hand Bryant's triangle to see if it's more of a supramalleolar problem or whether it's
it's equal on both sides, but they're very small.
Very small. Okay.
Okay, good. So what investigations would you like to do?
So my investigations, I would like to do radiographs of the patient's spine to further potentially.
That's the spine and the hips.
And the hips, right. So looking at the radiograph of the spine, AP radiograph, I can see that there is a right-sided curve. looking at the radiographs of the hips, sorry, to minimize that, I can see bilateral hip changes with loss of the ossification or loss of the femoral heads. My concern is this potentially is secondary to a DDH type picture. It's not been treated. It looks like they are
DDH
or
type picture.
Not necessarily, because the hip is not necessarily, but I think there has been a change in the hips.
So in DDH, would you lose the ossification center at 6 years old?
No, you would expect not to see it at all. So this isn't a DDH picture. I'm sorry.
Okay.
There is a change. There is almost a loss of the bilateral femoral heads, potentially to a variety of different reasons. This could be secondary to AVN or Perthes, or secondary to further.
Is AVN Perthes what type of spectrum of diseases we are talking here about?
So in terms of the child, I think the child has a skeletal dysplasia.
Skeletal dysplasia, is Perthes or AVN included in skeletal dysplasia?
They are not, but a child could also still have them, but it would be unlucky and unusual.
So AVN in both sides? Again,
no. So the hip changes, looking at his hip change, would be more in keeping with something like an MED, so multiple physeal dysplasia. So
but what do you say about the spine?
So then it would be more of an SED. So
SED. So we're talking about SED. All right. So hips, back to hips. How would you manage this child?
Okay, so I'd manage the child by talking to the child and to the parents about, in terms of their aims of treatment, how much it's really affecting him, in terms of how much his functional demands. We know he's not really playing so much at school. In terms of the spine, the options for treatment, I could measure Cobb angles and further delineate the level of deformity of the spine. But the options are bracing, which is not always that effective, or it'd be thinking about
why it's not effective, although it is a low degree of scoliosis.
So it can be effective. It helps support the spine and helps to prevent progression, but it doesn't correct the deformity. And it sounds that he seems like he's already got a deformity, which most likely may progress.
What do you think the Cobb angle is?
So the Cobb angle,
is it mild, moderate, severe? I don't want the degree.
I would say this is probably more of a moderate Cobb angle.
That's right. Is that more, or the hip pathology is the more concerning thing?
I think the hip pathology is more concerning, as this is likely to progress. I would want to treat this as part of an MDT approach with the pediatricians and the physiotherapists. Want to get.
Okay, thank you, Melissa. Thank you. That's it. Take a deep breath and rest now. Right? Okay.
We'll be moved soon.
Yeah. First thing. Yeah. You did well. I'm happy with your answers. It is a shocker, and recently they have started to put complicated pediatric cases, things that never been in the normal, old pattern of. And this was in one of my courses I did during the preparation, so that's why I brought it up. But in real patient, so. In the history type, I'm happy with the history, although you missed quite a few questions. Like I tried to prompt you by the eye test, okay? Because if it's an SED, it's an eye, and hearing problems, okay? So that's from the history. In examination, yes, a little bit bumpy, but have a sequence of what do you want to ask and what do you want to go further. The hips are the more concerning thing, because this is Coxavara and the great angle. Yeah, and MDT, you said it actually after the time, okay?
So will it count?
Hi guys.
Hi.
So this is your lower limb intermediate. Who's going first? Is it Benjamin and Asif? Is that right?
Yeah, yeah,
Yeah.
Asif. I can go ahead. I can go ahead.
Right.
Okay. So let me just
So
get my.
share your screen.
Share
Yeah.
your screen, Mu'taz.
Yeah. I'm just
Muaz.
doing it now. Sorry. Yeah. Can you see the screen?
Yes, he can.
So
Okay. So this is a 57-year-old lady. She's presented to your clinic with a referral letter from the GP. And the GP letter says that he's been seeing this lady for some time with bilateral knee pain. It's got worse over a period of years. He's tried analgesia, he's injected her knees a couple of times, and he says that the pain is just getting worse and he wants your orthopaedic opinion. So you've got 5 minutes for the history, first of all. So what do you want to know?
So I need to know the age of the patient and his level of activity, and how long is there any surgery done on this side, and how long the pain is there, and how it is affecting his daily activities. And I would like to know generally his overall mobility as well. And precisely, I will ask him to tell me where exactly is the pain, and how much is the pain on visual analog score. And is there any radiation of pain proximally or distally? I will look in and out of the box, particularly the spine and the hip, as well as the distal part. I will look for, I will ask him, is he having any other pain? Is he having any previous surgery done? And was he pain-free after the surgery or not? I will also like to know, is he having any fever now? And he's generally fit and well. I would like to know the other past medical history, particularly diabetes mellitus, immunocompromised, peripheral vascular disease, and I want to know what is his expectations.
Okay.
And in addition to that, I just want to gather that is he.
Fine. So I'll give you some information. So it's a she, so it's not a he. So it's a 57-year-old lady. She has had pain on and off actually now for quite a long time, probably about 30 years.
Okay.
And she did have surgery when she was in her early 20s.
Okay.
She can't remember exactly what. She said she was having problems with her knees. It was an old surgeon who retired, and there's no records, but she did have some surgery on both of her knees in her early 20s.
Okay.
It's got worse over 30 years. She was managing fine, but over the past 2 or 3 years, she's really deteriorated, and that's why she's taking more analgesia. She's taking cocodamol, 8 tablets a day, so she's maximized that. She's had a few steroid injections. In terms of her mobility, she's still walking independently, but if she walks for a long distance, if she goes outdoors, she has to use a stick. Past medical history, she's got hypertension, no other significant past medical history.
So I need to know that before,
and no pain from the spine or the hip, as you mentioned, no pain from anywhere else.
Okay, so this is a good thing actually. The only involved is the right knee. I want to know that before this surgery, was he having any long-standing issue or no, like dislocation of the patella or any other issues? Is there any history of
not
trauma?
particularly? She had surgery when she was in her early 20s, and she had.
Tell me what exactly the surgery was at that time?
Can't remember. She can't remember. She said it was a long time
Was
ago.
there any metalwork put in or
No.
not?
Can't remember. I don't think so.
Okay, because we are lacking the information here, so I will proceed with the examination.
Okay. Do you want to summarize the history?
Yeah, so she's a 57-year-old lady who is having pain in the right knee from last 30 years or so. She cannot remember what exactly happened at that time, but there is a clear history of surgery which was done, and the surgeon is retired now. Since that time, she has pain, and it is affecting her daily activities. And otherwise, she's fit and well, apart from high blood pressure.
Yeah. Okay, fine. So you move on to the examination. So you see her knees, and this is what you see. So just describe what you can see.
So these are the clinical photograph of a knee. I can see there is a prominence on the anterior aspect of the knee with a previous scar mark.
5 minutes. No.
Dimpling as well, bit of dimpling there. The attitude of the limb is in slight flexion.
So you said you can see the scar there on both sides. What do you think might she have had? What kind of operation?
So there are two options. I can't figure it out. It's me on the medial side or on the lateral side. So can you guide me?
I think it's on the lateral side.
It's on the lateral side. So it could be lateral patellar release. It could be some infection at that time.
Okay.
So
fine. Okay, just move on. So in terms of the examination, what do you want to do in terms of how would you examine this knee?
So I will ask her to stand up and see is there any fixed flexion deformity. I would like to see the hip as well. What is the attitude of the limb?
Yeah.
And then I will ask her to walk and see how she walks. Is there any intelligent gait or any specific sort of gait? I will look back in the popliteal fossa as well to see that there is no other scar mark there. And then I will ask her to sit on the edge of the couch and ask her to kick out the knee to see that how much she has got the movement, and I can at the same time I can look at the quadriceps, is it intact or not, and I will ask her to perform the SLR. On the couch, I will again see that there is no leg length discrepancy, and I will position both the sides and measure, but initially apparent and then true leg length discrepancy. Focusing on the knee, basically, I want to know, is it passively correctable or not correctable? And how much is the flexion from this point onwards? And I will do the I will do the palpation to see where exactly is the pain, what is the temperature, is there any
fine. So just to move on, so in terms of her gait, she does have a slightly antalgic gait. It's worse on the right compared to the left. She has a slight valgus alignment of her knee.
All right.
And her range of motion is actually quite good. She can fully extend the knee, and she can flex to 100 degrees. In terms of the pain, she says, both in the history and from this examination, is global. It's not focused on one side of the knee. The whole knee is quite painful.
Okay.
So,
history, I have asked her already that she has any pain in any other joint. So I'm concerned about
just the knees.
Rheumatoid arthritis as well. So is she taking any medicine for rheumatoid arthritis or not?
No, she's not.
I will see, because she has a valgus deformity. I would like to know that the medial structures, they are competent or not, particularly the medial lateral ligament. And again, as I mentioned previously.
How are you going to test that?
So I will try to see that is it correctable or not. Is it a fixed valgus or it's correctable? And then I will go for X-ray of the knee.
Okay. So if it is correctable, does that mean that the collaterals are insufficient or sufficient, or how is that helping you?
So I will apply the valgus stress test and see. Is it competent or not? It's a frank, I mean, I have to see the end point as well. If it's a soft end point.
Okay. So she does have an end point, yeah. So the collaterals are intact. Okay, so you wanted some x-rays. What x-rays would you like?
I would like to get AP and lateral and skyline view as well.
Okay,
and
so
the baseline bloods as well.
Not the best quality x-ray, so apologies for that, but this is the right knee that we want to focus on. So what can you see there on the AP? It's a weight-bearing x-ray.
All right, so this is AP, both are AP view, slightly different on the left-hand side.
Yeah. Just focus on the right side.
On the right side, yeah. There is good joint space.
Sorry, the right knee, so left of the picture.
Sorry, right, yeah, on the left. So there is increased osteopenia in the medial tibial plateau area.
Okay.
And there is increased signals in the distal femur, increased sclerosis in the femoral.
5 minutes.
Sorry? Yeah. Femoral condyle area. There is a bit of subluxation.
You're looking at this knee, aren't you?
So I can see there is a valgus deformity.
Yeah.
And there is a bit of subluxation on the medial side, medial femoral condyle. And in this case, I'm concerned about the lateral femoral condyle bone loss and also the competence of ACL and PCL. I would examine, but it will be very difficult to see.
Yeah, I agree.
I will send the bloods of this patient.
You said you wanted to see a lateral as well?
Yeah, definitely.
Okay.
So on the lateral view, the patella is absent, and there is no posterior subluxation of the femur. It looked like the PCL seems all right. So
Okay,
it's a complex situation.
Yes.
And I need to know what is her expectations, and I will involve my, because it's a sort of complex case. It's not a simple one.
Yeah.
I will take the advice from my revision surgeon, because if we have to do anything surgically, it will be a complex primary, and PCL stabilizing knee is needed rather than jumping for anything. But we need to know what is her expectation.
So her expectations are that she's at the end of her tether, she's in a lot of pain, and she wants a definitive solution.
From here, it looked like she has exhausted all the non-operative management.
Yes.
I will go for, I will speak to my...
yeah, so you've discussed it in the MDT, so what are you going to offer?
I will send the full blood count CRP, I will do the CT to look at the lateral femoral condyle deficiency, and I will refer him to the...
Fine. So let's say you're in a specialist center, you're the specialist.
So the complexity here is the approach. I will go for medial parapatellar approach. I know that some people go for lateral parapatellar approach. If it will be difficult case really, so maybe there is contracture of the quadriceps and exposure will be difficult. We have to do the lot of medial releases and I will not use the white side. I will use the white sideline. I will not use the posterior referencing in this case because it can lead to internal rotation of the femoral condyle. And I will go for posterior stabilizing knee replacement. In addition to that, before proceeding to this stage, I need the wrap to be there. I need that I have all the materials. If the medial collateral ligament is not competent, maybe we have to go for varus valgus stabilized knee, so that I have all the ladders going all the way to the hinge knee.
Tell me the principle of a PS knee. So you said a posterior stabilized knee. Why would you use that? How does that work?
Because in the posterior stabilizing knee, we have a cam and the cam mechanism, peg and a cam mechanism. And most of these patients are PCL deficient. In that case, as we flex, the cam engages the peg and it gives posterior stability to the knee joint.
2 more minutes, feedback.
Fine. Okay, we'll stop there. So what do you think? How do you think you did?
Reaching to the absence of patella was difficult.
Yeah, it is. Yeah. So I did the exam 2 weeks ago. This was my case in the exam.
All right.
Yeah, so this is the exact case I got. Yeah, it's an interesting case. It's not a straightforward one, so it's quite difficult. So I think you did really well. I think you were systematic. I think your history was very good. You have like a spiel, and I think sometimes it's advantageous to just keep talking, but also listen to the examiner. So I said to you when we got to the management, I just said to you, what do you want to do? She's exhausted all the options. And I appreciate you want to go through the ladder and you're saying, but just, I asked you a direct question and you want to just, score the points. So just listen to the question that I'm questioning. Yeah, the score is quite difficult. It's not one that you see that often. I just got this off the internet. So I actually had a transverse scar over the front of the patella. So this is maybe a bit misleading. So apologies for that.
Yeah, it's
but you understood the principles of a valgus knee and the approaches and what kind of releases and the issues with rotation. I think you probably need to do more lateral releases. You said medial releases. I think you need to do more lateral releases and about.
Yeah. The contractor part is that, but it's the flow of the exam. Yeah. This is the convex side, the medial is, and the concave side is the lateral side, which need release.
Yeah. So you need to do more lateral releases, and yeah, you're right. I think most people would still use a medial parapatellar as that's what you used to, but you can use lateral as well. You can see here on the AP X-ray actually, if you look closely, there's no patella on this one. Yeah, so that was the other clue, but it's difficult to spot. I didn't spot it in the exam as well until I saw this X-ray. But overall, that was good. I think the next conversation would have been talking about what type of knee, NJR data, and why you would use a certain type of knee. But overall, I think you did very well. Very good. Definitely a pass. Good pass.
Good.